Hi, I'm Tyson Franklin, and welcome to this week's episode of the Podiatry Legends podcast. Before I introduce my amazing guest today, just to remind everybody that in July, Jonathan Small is coming over from the UK, and him and I are teaming up together, and we're going to be running the Work Smarter, Not Harder 2-day event. It's on the 21st and 22nd of July. All the details are on my website. Just go to tysonfranklin.com. Click on events and you'll see all the information there. It is going to be a fun 2 days. There's only 30 seats, and I know about 10 seats are already gone. So don't sit on the fence for too long. Okay, my guest today is a sports podiatrist from Arlington, Virginia. It is Dr. Ben Pearl. So, Ben, how are you doing today?
I'm doing great. Spring has finally arrived, and it's just good to be out and about commuting. Literally just got back from my bike commute from work.
I have been to Arlington, Virginia. I was there 2014, I think. It was great. I didn't realize how close it was to DC.
It's a hop, skip, and a jump. I mean, I think they say George Washington threw a silver dollar across the Potomac. I don't know if that's just legend, but yeah, it's great. I mean, we're so close to the cultural stuff. We're having our Academy of Podiatric Sports Medicine meeting, in the USA. That's going to be in October. Mike Donato is the current president, and a really good scientific presentation that they have gathered, including some people across the pond. The last one we had was in Seattle. They had Craig Payne come over from Australia. So
okay, yes, I know Craig. Craig's been on the show.
Yeah.
So yeah, well, I was there for a podiatry conference, and I think it was September, October. So it was really nice weather. But yeah, just a beautiful place. But I imagine it gets cool in winter, and you must look forward to the spring.
Absolutely.
Okay, so let's dig into the Ben Pearl story. I always like to find out from people, why podiatry? What got you started in podiatry? What made you think I want to be a podiatrist?
Well, I had as a guest just recently Clifton Bradley, who had a track story. He was an elite track runner. I was kind of middle of the road track runner, but I decided I'd done cross country in high school.
Yeah.
And fair runner, and decided I went to Indiana University. That was in the days when they had Sunder Nix, Olympian Sunder Nix, Jim Spivey, who you may remember that name. And I was not in that caliber, Tyson. I was a walk-on. But it's a fun story because just prior to me getting into college, I had a teammate of mine that got a compound fracture, literally. This was at Burke Lake, not far from here, about 30 minutes away, at a regional meet in literally the last 100 yards. And the reason she did was she was training too hard. Women sometimes get amenorrhea. The bone deposition isn't as good, and she ended up with an undiagnosed stress fracture that broke at just before the finish line. And that kind of created a little bit of a light bulb. Boy, if only there had been some medical personnel tied to the team or somebody that was monitoring this. And that kind of sparked the idea. And this was in the days when George Sheehan was real big, and there were some podiatrists that were also up and coming that were writing books with different medical sports medicine gurus. And so, this was in, just coming out of the 70s and the early 80s. And then when I got to IU, I decided to go out to track as a walk-on. It was, I would end up in on the golf course, the IU golf course, trying to find the women's team, because I was that, they were that ahead in terms of caliber. We had 2-day workouts. I ended up hurting my Achilles tendon in the rehab area. I just said to myself, you know what? I am putting out, time into this. I'm, falling asleep in my books, studying pre-med, and just wasn't worth the time interval. Changed over to bike racing. Ended up having a lot of fun. They have a bike race there called the Little 500. So did that bike race, which ended up working a lot better for my Achilles tendon. And then, pursued and stayed on track to complete my podiatry career.
So,
and
but
went
why
to
podiatry?
Philly.
Why did you choose podiatry? Like you did pre-med, you didn't know that you were going to do
Yeah,
podiatry
so
beforehand?
I think from just the wellspring of things that I saw from injuries that I had come up with when I was coming up through cross
Yeah,
country, and then my own personal injury. And I've always been very sort of solution orientated about what little changes can I make in my own training. Who do I need to visit to fix this? And I really like the idea of right away knowing I'm going to be addressing sports medicine, lower extremity kind of issues with the field of podiatry, as opposed to going into, like, let's say, general medicine,
yeah.
where, if you're lucky enough to get an orthopedic residency, they become very competitive. You then find your way through medical school. And I like physical therapy too, by the way. I think that the thing that I like about what we do as podiatrists is not only do we get to treat, make protocols, but I love the diagnosis part.
Okay.
That's always been, kind of a Sherlock Holmes kind of a thing for me, and really delving into the nitty gritty to, differentiate between a stress reaction and a compartment syndrome. Those little nuances of what we do didactically and study-wise to separate those things.
Yeah, it's true though. As podiatrists, we are like detectives. We have to dive in, and you're going through all the symptoms and looking at all the clues, and then pulling on your past experiences of what you've seen before, and even reaching out to other colleagues and asking them questions. I've got this. What do you think? And then eventually putting something together. And I think every time you treat a patient, it's like a feedback loop on what you'll do for a future patient. And that's why, when they say, nothing beats experience. The more patients you see, the more you treat, the better it is for your future patients.
I agree 100%, Tyson. It's kind of like that veteran quarterback that's got all those plays and all those, hot reads of the safety coming off the blitz and things like that. So he knows, that I'm going to do that route. And, one of the things I was talking to a colleague about is not hesitating when there is not clarity to get things like an MRI, for instance. I mean, I have diagnostic ultrasound in my office, but I've had a couple of cases. One is somebody that has, we're trying to differentiate between, typical runner's knee things and a medial meniscus injury, in which case she'll probably be referred to an orthopedic surgeon. But there's a foot pathology there too, because the foot function is influencing the knee. But at the end of the day, the knee's going to trump if there's degenerative meniscus.
Yeah.
And then I had an ankle injury, did a sonogram, but wanted to dive a little deeper into some of the anatomy. And the patients appreciate that. I'm not one to just get advanced studies arbitrarily, but at the same time, I think that, with experience, I've seen situations where I've had patients where they're still, for them, they're not convinced with your clinical sort of processing and the studies that you're doing in the office, and they want that extra assurance sometimes. So sometimes that's what you have to do to retain the patient and keep the progression of their movement forward with their injury.
Yeah. So once you finished podiatry, you would have done your residency. How did you choose where you were going to work next? What was one of the deciding factors?
Well, mine was sort of by happenstance. I was supposed to go into the Air Force to do a trauma program after my Veterans Hospital Philly residency, where I saw a lot of diabetic, a lot of we had a gas gangrene case, all those kind of infection type cases. And yeah, we had some bunions, some Keller bunionectomies, but it wasn't a high power sort of 4-foot, reconstructive kind of program. It was more the nuts and bolts of, dealing with vets. So when I had the opportunity to meet a recruiter in the medical field with the Air Force, they said, yeah, we got this program out in Travis, out in California. We're going to put you with jumper injuries and so forth. And I was like, I'm all about it. Well, what happened subsequently, and this is not uncommon in U.S. military medicine, they put the best face on what they think you might be able to get into without knowing what the actual spot allowances are. So what happened was, it was a bit of a bait and switch, I have to say. They didn't really have that space open. They took somebody that had already sort of went up the rungs in the Air Force. they offered me as a bypass, hey, we can put you at a clinic down in Texas. You can work with diabetics. I said, I kind of had that experience already with my residency. So I found myself in private practice, worked with a guy who was taking his honeymoon to Greece in McLean, Virginia. And, you know all about this. I've been watching some of your topics of developing those relationships, mentoring and staffing. And listen, I was as green as the day is long. He was probably not the best mentor. It just wasn't a fit. So after a year, I kind of got the heave ho and found myself, oh my gosh, I got to figure this out myself. So luckily I had colleagues in the area that had come from the Philly school, Temple, and a little bit of this, a little bit of that, a little bit of white knucklers, just trying to figure out how you're going to all put it all together. And subsequently I over time developed a sports medicine podiatry practice, and I still do the general podiatry, ingrown toenails and stuff. I don't think most people are lucky enough that they can just subspecialize, but it is certainly, as you grow it, you become it, and then you get more of it.
Yeah. So what's the name of your business?
Arlington Foot Ankle.
Okay. So you don't put the word sports into the actual business name itself.
I don't, and I've had colleagues that have had in sports medicine, and I've thought of that. So it's, in terms of whether to rebrand or not, I don't know. What do you think? I've been doing this for that title for a good 25 years. So I guess I'm mildly concerned that if I add the sports medicine and it'll, all the algos on the web and everything, and whether that would then dilute folks finding me. So that's the main reason I haven't and then the length of the title too, to add the Arlington Foot and Ankle and Sports Podiatry or something of that nature.
Yeah, I suppose it's one of those things too. Well, I think it's one of those things that if you want to see everybody, a broad range of patients, but then I wouldn't put sports in the actual title.
It might exclude people.
Yeah, if you want to bring it down to, no, I've built up enough clientele that I just want to focus on sports, I would put sports in the title, because then you find that just that word alone will probably repel a few people if that's what you're trying to do. But I also think if you've got your business name there and then they go to your website should pretty much scream what it is that you do. So a lot of people will see that. And if you mention that you see everything, then people will still come in for routine care. But if your website screams sports from start to finish, then there'll be some people go, oh no, maybe that's not the clinic for me.
Yeah. And we try to put a good bit of what we do that might separate us, do the 3D printing. A lot of clinics do running analysis. I've spent time with running clinics. I've done some assistant coaching. I wouldn't call it like I'm the head coach or anything, but I've assisted coached some high school run programs over the summer in SUNY New Paltz, upstate New York, with a track coach up there that I became friendly with, and good experiences that have helped round out what I'm doing in the sports medicine arena.
So when you're working with a team, like assistant, say track coach, what do you specifically do as a podiatrist with that team?
Yeah, I try to get the kids, because they're high school kids. In the case where I was doing that rotation, it was a 1 week camp. So it was a brief snippet, but it was pre-training for the high school season and kind of getting the kids geared up that were coming up and wanting to participate with varsity, and then looking even some beyond into what a college program might look like. So because they had it on a college campus, and I provided information for the kids about sports medicine, about the field of podiatry, talked a little bit about injuries. I participated with the runs with the students, and just kind of filled in. And then there was some collegial interaction with the coaches about just different stretch techniques. I ended up on my podcast inviting one of the coaches who's ends up being he's a Hoka ambassador, but he also is a track coach. He was almost Olympian in steeplechase. Tommy Nohilly is his name, and he does the active stretching, right, with the assist with the nylon ropes and such.
Yeah.
And so I came to gravitate towards that active stretching as opposed to just doing passive stretching, and just really good regimens that he's taught me up there, and I've tried to emulate some of them and had him interviewed on my podcast. So nothing too intense, in terms of being like at a more advanced sports medicine clinic, but it just was a great experience, and I loved doing it. Good energy from the kids and the coaches.
So with your sports clinic at the moment, what percentage would you be doing sports compared to, say, routine podiatry care?
Luckily for my passion, it's increasing.
Yeah.
Today I had that knee case, and she also has a hallux limitus. And what I find, Tyson, too, is it's not about necessarily anymore the numbers of patients, because with one patient, when you start with multiple lower extremity problems, that becomes, I wouldn't quite call it a boutique practice, but you're spending a lot of time with those patients.
Yeah,
so
that makes sense.
Come again?
No, I was just saying that makes sense.
Yeah. So I'm trying to go more with quality and not quantity. And to answer your question directly, I would say I'm probably hitting at about 20 to 25%, which has increased. I mean, it used to be, several years ago before I started my podcast, maybe 10%. But as I've kind of gotten the word out that that's kind of what my passion is, and what I can offer, creative and specific solutions, because everybody wants very sport specific solutions. I was a ski coach too, so I've got that background. That has been able to increase, and like you say, the overlay with the website and conveying that, that experience that they're going to have, the patients.
So what's the name of your podcast? May as well give it a plug, because you...
Oh, yeah. It's called Fit Foot You. Originally, I called it Doc for Jocks. And then, I was thinking to myself, really when you want to bring people in, it's about them, right?
Yeah.
So a yoga instructor, I went to a yoga retreat. He said, Ben, you're talking about fitness, you're talking about the feet, you're trying to make it kind of all encompassing. And then you're also talking about them, the patient. Why don't you call it Fit Foot You, and then play on words, you like university, like we're, trying to help educate people. And I have both, I try to educate both lay people and then also other physicians, other healthcare practitioners, because we have a little bit of everything: athletes, coaches, people like you, all sorts of people. So
yeah, when did you kick that off?
It's been a fun ride.
When did you start that?
I really started in earnest during the pandemic. I was doing a blog prior, Doc for Jocks, and then during the pandemic, I got extra time, and I think that's when a lot of well springs of podcasts came about, right? So and then really, gave us a chance, right, during the COVID to sort of take a step back and recalibrate and decide, what do I really want to do with my practice moving forward here?
Yeah, I think that happened with a lot of people during the COVID years. Was a lot of people, they stepped back and created. There's a lot of podcasts that came about. There's a lot of Zoom shows and video shows that have come about during that time, because we were all sort of like disconnected from each other, and it was a way of connecting everybody back together again. So yeah, there's been, other than all the devastation, everything else that went along with COVID, there has been some positive things that came out the back of it.
Absolutely. And I feel like one of my goals, I was talking to this with you prior when we did the pre-interview.
Yeah.
I worked at I was lucky enough to work at a collaborative clinic at the National Institutes of Health, a big deal. It's right Bethesda, Maryland, up the road. It's about 40 minutes away. And at the time, the physiatrist, she was head of the rehab department there. And she did a lot with children's, with clubfoot, with different type of neurogenic diseases, all kinds of rare autoimmune arthritides and so forth. She invited me to participate in this clinic, and my dad was a research scientist at NIH. So he had heard somehow through the grapevine that they were starting this foot clinic. So I submitted a resume and I said, I'd love to be involved. And we had orthopedic surgeons, we had biomechanics PhDs, we had physical therapists, we had physiatrists. And it was the true grand rounds, like from Johns Hopkins right up the street, where literally you would have that one patient and many practitioners offering up, presenting, and giving their opinions. And usually there was one lead presenter, maybe somebody that had worked with that patient. And then we would all have an opportunity to collaborate and give some of the type solutions that we would see from our point of view. And what I think is great about like what you're doing and what I'm trying to do is we are trying to break down those silos and get that cross-pollination and crosstalk, so you don't have these vertical silos. And, you know, for me, I'm a lateral thinker. And I think the most frustrating thing for me is when, you know, we put a lot of effort out to provide information. And sometimes you have, you know, folks you run into in our profession, in other professions, you know, they see you know, a hammer, it's always a nail. They see a nail, it's, you know, like that.
Yeah.
So, you know, I really like thinking outside the box. I think it's very troublesome to me that, you know, we've studied a lot, put a lot of effort, and you're focused on these bunion surgeries that here in the U.S. United Healthcare might be paying $390, you know, to put a couple screws in somebody's foot, and that's, you know, that would be a case where, you know, kind of the lower end tier. But when you look at it, right, you know, we all want to have a balance of life quality, work quality, and if you're not lined up with that so-called surgery practice where you got residents to help you close and you got the whole rotation going, that's not the way to practice anymore for most people. You got to find other solutions to keep the chains moving. And I've been fortunate when I've talked to my guests that I have on my podcast, and, you know, the biomechanics summit that I'm going to be doing my third one, where I've been able to get some high caliber speakers that, you know, you get a little bit of something from everybody. You know, you'll get a tip, something that'll change how you look at that patient in front of you.
The one thing I've noticed with yourself, you know, talking to you, and we spoke prior to doing the recording on the podcast, and other people that are in podiatry, or say are involved in sports podiatry, is you can tell they're eager to learn more. No matter what they know now, their mind is so open to, I want to learn more. I know there's other things that I don't know, and they're really eager to find out. They're very open to admitting, I don't know everything and I want to learn more. Whereas I've seen other people who have been in podiatry, whether it's 5 years, 20 years, where it's like, I know enough, and they close their mind off and go, I don't need to know anything else. And I think it's really interesting to just keep your mind open and understanding that I don't know it all. In fact, there's so much more I need to know. And the more you keep learning, the better you're going to get.
Absolutely. I mean, I could give you so many examples of things just even in the last few months. And sometimes what happens too with me, Tyson, is I'll listen to one of my own podcasts, because sometimes the information is so layered. You have to kind of go through it sequentially to really glom onto it. And well, this is just, you know, a little thing that I was doing with neurogenic function. Richard Blake, in his book, his wonderful biomechanics, I guess he's on his third book that he's of a series, practical biomechanics for the podiatrist. He was talking about neural flossing. I'd never heard of neural flossing. It makes sense, you know, you kind of stretch, extend out, you know, the legs, and stretch the nerves out, and reciprocal inhibition, and a lot of different things. And I thought that's great. You know, that's yet another tool that I can add. So if somebody has an aroma, you're not just thinking Morton's pad, spread the toes out, things that were, that are very popular and talked about right now, but
Yeah.
thinking more in terms of the entire kinetic chain.
Yeah. And that's why I think it's important to, and just because somebody, say, may write a book or may have a PhD or does a presentation doesn't necessarily mean what they're saying is accurate all the time.
That is true too.
Because you
That
can
is true
read
too.
something and listen to someone talk, and you might go, that may work great in a university setting or a lab setting, but in reality, in my practice, when I only have 40 minutes with this person, not 4 hours, how do I apply that into 40 minutes? And that's the part sometimes where I think it's great to get a lot of point of views and then also talk to people who are in the field doing it. They've heard these before. They're now applying it. And I love actually hearing them speak as well.
Absolutely. How do you
Which sort of
synthesize
leads on
that?
to what your summit is all about. Your biomechanics
Yeah.
summit that you've put together is really bringing people who, not just the theory from the universities, it's bringing the people who have actually done it. And then they're talking about practical use.
Yeah. So for instance, the last one we just did, we had Simon Bartold, who, has had the opportunity to be a consultant with ASICS, with Solomon. And really, he has his own Bartold Clinical and really lives and breathes this stuff and really thinks about it. And we'll have a little new twist. He had a new twist on osteochondrosis type issues with children. And one of the things that he said that I thought was brilliant was that at that time of puberty, as you're getting into puberty, there is a period of hormonal change that will lead to a transient osteopenia. And to me, like a light bulb went off. Boy, I never really thought about that aspect. I mean, I know it's, a lot of these things are theorized.
Yeah.
But at any rate, what that light bulb that put into my mind was something that I've been passionate about and looking about is another modality of yet many. We have shockwave, we have electromagnetic energy, we have different types of injections, regenerative injections, placenta. So one of the things that I like in particular, or that I've been looking at, and I was going to just touch on briefly, is I said to myself, well, if I'm looking at electromagnetic energy, we already know it helps with bone healing. Maybe there's a window there with some of these kids' growth plate injuries that might be helpful. So I talked to Simon about maybe taking a look at that. And that to me would be wonderful if it could come to an actual collaboration of research, bypassing just a brief conversation. But just even in terms of getting the wheels turning, I think that's an accomplishment right there in and of itself, because now you're integrating and putting together. That's not just a piece of knowledge that I'm going to just sit on didactically. How can I use that to help my patients and to provide better outcomes?
So you're going to try electromagnetic therapy in your practice yourself on your own patients, and then you have been doing it. And what sort of results have you been getting with it?
I've been getting very good results. I put them all up on YouTube. Most of my patients, I don't show their faces. I ask the permission. That most people in this day and age, they want anonymity, and I completely understand that, right? But it's nice to hear from the patient standpoint. Like I had a patient of mine that had an ankle sprain, grade 2. ATF was still there. I showed him on the ultrasound in the gutter, on the sonogram. Yeah, it's dark, hypoechoic, but yeah, your ATF is still there. It's still tethering a little bit and not ruptured or anything, just a minor tear and stretch. And but he wasn't able to bear weight on one leg, single leg stance.
Yeah.
So right after he had the treatment, which is bone inductive, it's sharing an electron, stimulating the mitochondria for cell permeability, for cell function, for cell repair, that whole cascade. We have ions in our body, the calcium channels, the sodium, potassium in all our cells. Anyway, the short of it is that he was able to stand without pain, and he told the audience that on the video. So that to me was a real good, solid approach. Where I'm having the ones that are a little tougher are some of the chronic injuries, like the chronic plantar fasciosis. Those are
Okay.
just tough. All the, you know, whether it be shockwave, whether it be injections, whether it be strapping, whether it be, you know, and I try to shy away from cortisone myself, even though I use it at times, just because I feel it's more of a mask than a cure per se. But those are the more tricky cases. I find that sometimes the acute trauma cases are the ones that respond more, as long as the whole, you haven't lost the whole ship. If it's a partial tear or, you know, sprain, that those types of situations respond very, very well to some of these energy type modalities that are out there now.
So with your biomechanics summit, so you do that once a year.
Yeah.
And when's the next one going to be? It's not till
So
next
we're
year,
gonna
is
do it. Yeah, we're gonna do it in February when things calm down a little bit from after the holidays.
Yeah.
And it gives people a time to recalibrate a little bit. I think, you know, like most people, right? We come back to our clinic, we're kind of overwhelmed with all the things that we had to wrap up with at the end of the year, and then getting back in the rhythm. And then I think people start then thinking about what they want to do moving forward, chew on it a little bit. And so I'm going to be shooting for that first week of February, second week of February, depending on coordinating, you know, the people across the pond. Last year we had Dr. Chalkingham as well. He did something with the World Health Organization on a study, a cursory study on use of orthotics with different types of foot conditions. So I sort of have to line up the best speaker schedules, and a lot of them are very busy, but then we'll pick a final date. But I'll be, you know, giving you an update so that you can share it with your international
do that.
people as well.
So it's going to be online, isn't it? You're doing this as an online
it is
biomechanics
online.
summit.
It's collaborative. What I'm going to change this year, because we got great speakers, and I never like to cut off a great speaker, but sometimes it gets so long and into the evening.
Yeah.
I am going to have the more collaborative part, the round table, in the middle of the conference. So that way, you know, it's, why do we always have to have it at the end? You know, instead of the end of the session, I'm going to put it right in the middle, get two of the more marquee speakers that people want to hear, get them, boom, boom. Try to have a quick 3-minute sponsorship thing. Brooks Shoes is going to be helping out this year with that, so that'll help a little bit defer some of the costs of it, and then get into where people can engage. And I hope to get, you know, more engagement this year. We had some engagement mostly between the speakers. So you had somebody like Golden Harper, who developed the Ultra shoes, the concept of the Earth type shoe, talking with Simon, and it was great because they all respect each other, even though they have maybe different points of view on the best way to attack foot function. But it was nice to have them in the same room without throwing knives at each other in the same virtual room.
Yeah, virtual knives. How many hours does it normally run for when you do it?
Yeah, so we do it for about 4.5 hours. I think that's about enough that, you know, that people can swallow.
I know, because I've seen some online events, and this is recently, but some people used to do live events, and then they've moved it totally online, and it goes for 2 days online. It's like 7 or 8 hours a day. And I'm like, I flat out maintaining my concentration for an hour when I'm sitting there watching something.
I think you lose too much to that runoff, like you say. I would rather have 4 hours, pow, and then what I do is then divide up some of the snippets after, and try to get some of the highlights and put them out so that people, you know, whet their appetite for next year's thing, and at least, you know, have a thought process that they can take to their clinic, even if they didn't go to the summit.
So can you share with everyone where the information is for the summit, where you put your videos, so if people want to check this out, they can sort of track it all down?
Yeah, so it's going to be, I do this in conjunction with the American Academy of Podiatric Sports Medicine. Okay. So Rita Yates, the executive director, she's been very kind about collaborating with me to put that out to membership. So she puts it out on her website. My website is arlingtonfootankle.com. But I also have a Facebook. And what I really should do, because you just gave me a light bulb, I should really create a Facebook page for my summit as well.
That'd be a good idea.
Yeah, yeah. That way people can, because not everybody's thinking me as a practitioner if they want to just, go to the biomechanics summit. And I think that would be good too. And then I can kind of cross-pollinate with that as well. And what's been nice too is that people that have participated with the summit at some of the schools, like Richard Blake, I've helped review his books coming out. And so he's been kind enough to put some of the stuff on his social media as well to get the word out that it's there. And I hope to keep growing that kind of collaboration.
Yeah, what I like about the people that you've mentioned, like Richard Blake, Simon, Craig Payne, they've all been on the podcast as well. So it means I've been getting the right people on here.
Yeah, you've had some heavyweights. And Clifton Bradley, what
He's been on here. He's been on here as well. Yes,
he is just, his story is just very compelling. He's so engaged with that pelvic asymmetry, and he's another person just looking at that angle and getting more comfortable with palpating the landmarks. It's what we should be doing. It's anatomy, and putting together the whole puzzle. It's been
what was
great.
funny?
What
was funny when Clifton came on, somebody beforehand, because the podcast now, it's been going 4 years, and Clifton was on one of the really early shows, and I'd already done the recording with him, and I found him to be a really nice guy, got on with him great, and then somebody sent me a message and said, "Oh, if you just give you a warning about guests, I would avoid Clifton. He's controversial." And I went, well, I've already done the recording with him, and I found him to be a nice guy. I said, but I love controversy. So, and I think that's what I try to bring on the podcast here is I want people to share their different opinions and views on things. And I don't always agree with everyone 100%, but I like people sharing their point of view and then let others work out from there what they think. And Clifton's episode ended up doing very well as well.
Well, I have a question for you, because I think you've thought about this in so many different ways with so many of your guests and so much of your content. I've talked about what I call sort of the retail foot solutions, which is part of getting solutions, right? It's out there for the public.
Yeah.
What I see, in the US is a little bit of a breakdown between what used to be tighter collaboration. And I'm not saying that every community, like if you're in Sioux City, Iowa, or Boston, there are very good relationships between like run retail stores and podiatrists and physical therapists, et cetera. But I think there, in my community, certainly, I think that has broken down a lot. I mean, that it's not like they're not using some healthcare practitioners, but they're competing against Amazon for running shoes. So everything has become center line, and they have become their own little fiefdom of foot solutions as well. And look, I think a lot of those guys, they're very experienced. They've been coaches, they've been elite runners in some cases that run those stores. But I also feel like that something is lost when you don't get, the mutual respect and, collegial sort of referral relationship. It becomes sort of this vertical silo. What's your thought process on that? And I guess the pinnacle of it, we have one, people could guess what the store is, but there's one where you have people like, and it's not a run store per se, it's a foot solution store.
Yeah.
And, they used to wear white jackets so that people got compared. These doctors, and these, they did the training and, they've spent almost $1,000. Then they come to you and their coin isn't so deep anymore because they've already, blown it on that. And then they have to the only alternative generally is to get, collateral shoes or something from that store. So I guess what do you see as some of the things other than educating the public, like on forums like this, that needs to happen moving forward to kind of give people a better shake of where the best place to get their foot biomechanics solutions is?
You could do a whole episode just on that particular subject. I actually have a lot of thoughts on it. Yeah. I have a lot of thoughts on it, and So like these foot solution stores that are opening up in Australia, there's a couple of them as well where they're not podiatrists. I don't know what the qualifications are, and they sell a lot of pre-made orthotics and they sell them for a lot of money. And basically, it's smart business people have set them up. Where I see the problem is those stores should have been owned by podiatrists. And podiatrists could quite easily do exactly the same thing. They could open up a retail outlet separate to the podiatry clinic that is purely targeting that market and own that in their town. But instead, they'll sit back and go, but I'm the real health professional. So there's a lot more to it than that. Like if I had my podiatry clinic here and there was one of those foot solution stores or something similar across the road from me, I wouldn't be happy. But I could have opened it up as well. And what it is, some business people have really just caught on to the fact that there's people who think they're going to get a better deal by seeing someone who's not super qualified, but they just tell a really good marketing story. And in the end, sometimes they end up spending more than what they'd spend at the podiatry clinic. And I do believe long-term, those sort of businesses that can only rip people off for so long before the tables turn on and people start realizing, actually, my friend went and saw a podiatrist, got a clear diagnosis of what his problem is, a clear treatment plan. Not only did he get the orthotics, he also got all this other thing that went along with it. And he's now doing great. And I spent the same money at a place who was not qualified. And now I need to see a podiatrist. So I think eventually the tables will turn.
The circle will turn. Yeah.
Yeah. I think they'll always be there, but I think what they change, some of the prices will come down. And then it's no different to nearly every pharmacy, chemist shop sells a pre-made insert. They're just selling a pre-made insert with a better story attached.
Yeah, absolutely.
And so I'm not a fan, but I'm also I'm not 100% against that retail solution. I just think more podiatrists should be probably involved in that retail solution. Sure. No different to podiatrists that now own shoe stores or sell shoes in their clinic. I'm sure a lot of places there were shoe stores way before podiatrists ever started selling shoes didn't like it that podiatrists are selling shoes.
Mm-hmm. And you may be aware of this already, Tyson, but here in the US, it's gotten so sophisticated and seamless that you'll be watching the Today Show and they'll have some pop guru talking about, running shoes.
Yeah.
And then Hoda Kotb says, oh yeah, I wear this one for my aerobics class. And then they'll segue at that commercial break to the store with a story of some, star college football player talking about his story about, the foot place that he went to get his orthotics. So yeah. It's a real, and I mean, that's big money because now they have, with the New York studios, they have synced in exactly when that marketing piece will go with the story that's happening on the network morning show. So it's quite sophisticated, the layering that they've been able to accomplish with that. So they really have leverage.
I think there's nothing. I think as a podiatrist, and if you're a business owner or you're working for somebody, I think nothing beats you connecting with your community. Is being out there, being seen, volunteering at different events, showing your expertise, letting other health practitioners in your area know what you're good at. And I do believe long-term, your reputation will grow as long as you're constantly out there being seen and being heard. So you do need to market your reputation at the same time. And to me, there's no difference between two podiatry clinics and one of them is on TikTok shaking their butt around and jiggling their assets. And I don't have those assets to jiggle, so I can't do that. So there's so many things that are sometimes unfair. It's just the way it is. But I think nothing beats, no matter how you look or what you say, your reputation long term. I think you can keep building it as long as you're being seen and heard in a professional way.
Yeah.
So
I think that's it. You keep soldiering on and staying passionate to what you like to be involved with, and the outreach in the community is important too.
Yeah.
And that's what,
Yeah.
you know, the one thing I like about the virtual outreach is you can connect with so many great minds, you know, on a Zoom call like this. It's, you know, that's, like you say, that's been the biggest positive healthcare communication change that we've had, both with patients and with our colleagues, is this right here.
Yeah. Yeah. Well, that's what I mean. Like, I've connected with so many people over the last 4 or 5 years, or 6 years doing podcasting, that I've got friends all around the world. I can go to a lot of different places and I can send a message before I get there and say, hey, I'm going to be in Nashville in October. Next time I've got 3 or 4 people go, hey, do you want to catch up for a drink? Do you want to catch up for a meal? And you catch up with these people, which is exactly what's probably going to happen in October. I'm going to be I'll be in Arizona, Chicago, and Nashville if all goes to plan. So if anybody's in those areas, please reach out to me. I always love a burger. So
well, you'll have to let me know the next time you make it to DC, if you do make it to DC area again. You know, it'd be great. I don't know if your podcast will enable you to check out the meeting that the Academy is having in October, the live meeting, but it'll be a good meeting.
What date is that on?
I think that's October 11th through the 14th is when that's going to be in October.
Okay, so that would
so if
be,
you're still in the States, that would be a good one to attend.
I think those same dates are the dates I'm going to be in Arizona at another event that I go to. The dates are very close, or it might be actually just beforehand. So, but I'll check it out anyway. So have you got a final, before we wrap up, do you have a final tip or something you would like to share with everyone? Bit of wisdom before we close off.
Well, I would just reiterate the thirst for knowledge that you've talked about. I think it's always good to run things by colleagues. You know, look, I'm going to give you an example. I was talking to somebody about differentiating, again, compartment syndrome from medial stress syndrome. And I talked to one colleague and he had a great idea. He said, you know, you could do an ultrasound, have the patient run, because that WIC catheter, that Stryker catheter, very painful, right?
Yeah.
And you really want to be fairly sure that it's a compartment syndrome. This was a particular patient that had ruled out with an MRI for any kind of fracture. But anyway, the short of it is that collaboration gave me an idea. Why not try an exercise exertion ultrasound and a pre-ultrasound and see if there's a difference? That'd be a good way to see the tissue changes in that. And then another colleague that sees a little bit more of compartment syndrome, he said, you know what I hang on? I just had lunch with him today. We had Doctor's Day here in the US, orthopedic surgeon. And he's saying, you know what I hang on? I hang on the story. If the patient tells me that their leg feels like it's going to explode, that to me is the compelling bit to get the compartment pressures, to get that tested. So I think like that thirst for knowledge and going the extra mile, because, you know, even you get an MRI, the MRI guy said, you know, what you could have done too, if you wanted to see something, had the guy run first and then get the MRI, which I said, yeah, I should have done that, you know, but it's like, so I think that if you keep pushing for another iteration, you're going to get more and more specific and more technical and more astute at the best way to solve a problem and to diagnose a problem. So that would be my clinical tip.
So thirst for knowledge.
Going forward. Yeah.
Yep, that's great. So Ben, I want to thank you for coming on the Podiatry Legends podcast, sharing part of your story and your wisdom in this area of sports podiatry. And when you get more details about your biomechanics summit as it comes up, please forward them on to me. But you're already in the Podiatry Business Owners Club on Facebook. So if anyone's listening to this and you want to join the Podiatry Business Owners Club on Facebook, come on over. All you need to do is answer 3 simple questions and you're in. So you're already a member there. So you can just post straight into the group and yeah, I just approve them when they come through.
I appreciate that, and I look forward to continuing collaboration, both like this and on the web.
Yes. Okay. I'll talk to you again soon. Bye.
Okay, bye. Thank you.